começar mais um bloco dos temas livres. Meu nome é Fabiana, vou moderar essa sessão. Doutora Giovana Galvão também está comigo, vai ser debatedora junto nesta sessão. E nós vamos apresentar agora o trabalho do Dr. Federico Lipsic sobre linfangiotomografia com contraste hidrossolúvel intranodal para obtenção de imagens do sistema linfático central em pacientes pediátricos.
Hello, my name is Federico Lipsic. I'm a diagnostic radiologist from Buenos Aires, Argentina. I'm now doing my fellowship in interventional radiology at Garrahan's Hospital, and I would like to show you this afternoon this lecture about intranodal CT lymphangiography with water-soluble contrast for imaging of pediatric central lymphatic system. Okay, so what are the objectives of this lecture? We want to evaluate the feasibility and to know the usefulness of this method of diagnostic. Is it possible to evaluate the lymphatic system of the pediatric population with CT lymphangiography? In our hospital, we have a 500-bed inpatient hospital in Buenos Aires that is a center of lots of other hospitals that come the patients to do studies and surgeries. So the requirement of the only MRI machine that we have is really, really high. So the chance of making an MRI lymphangiography is really difficult. So we thought as a team, why not we try an intranodal CT lymphangiography for our patients with lymphatic system disorders, that there are lots of them. What are the causes of the lymphatic pathologies? We know there are anatomical variations that can cause lots of lymphatic pathologies. We've seen mechanical obstructions, tumors, for example, that can cause lymphatic disorders, and mainly overproduction. So we're not going to talk of this because then the lecture will be really long. Let's see, what are the most common lymphatic disorders? We've all seen this in our hospital practice. The pediatrician or the clinician calling you, hey, you're an interventional radiologist, we need to do a drainage of this patient with hidrossolúvel. He cannot continue, we need to do the drainage. You do the drainage. 1 week after, the same patient comes back, again with ascites. They don't know where it comes from, you know it's chylous, and there's no way or nothing to help the poor patient. The same happens with chylous effusion. We see lots of patients with dyspnea that need a drainage as an interventional that we need to do, and it comes again, and there's mainly, we don't know where it comes from, how can we stop it? So this is something really common in our practice in pediatric population and also in adults, the lymphatic disorders. So how do we perform a CT lymphangiography? I know maybe you've heard about the MRI lymphangiography. We do a similar procedure. We take the ultrasound machine into the CT scan. We perform an ultrasound in both inguinal regions to find the best inguinal ganglion. There's an example of one of them. Then this might be one of the trickiest parts of the procedure. We take a 23 gauge needle and do a puncture that needs to be exactly in the transitional zone of the ganglion. This is really important. The needle usually is a spinal needle, so it's a really long and thin needle. After we do that, we do the water-soluble iodinated contrast injection really, really slowly. We use what we call a number 5 rule. 0.5 milliliters per kilogram of contrast in 5 milliliter syringes during 5 minutes. So the injection is really, really slow, and we do it really, really slow. It has to be in the transitional zone, as it shows in the image. And then we show here some lymphangiography pictures showing how the contrast goes up to the central nodes. Then we take a slice at around T10 to see if the contrast is in the lymphatic duct, and then we do the whole scan. Afterwards, we do a volume, and we do a 3D post-processing. Why we do it? Because it's easier sometimes to see the anatomical variation and mainly to see the leak. Here, for example, we have a pleural effusion where we can see there's a leak in the left side, and also we can see another finding, we see a double thoracic duct. So that might be also a difficult thing to think about in the CT lymphangiography. Here we have several other patients. Here we see another chylositis that we perform a CT lymphangiography and we find perfectly the leak where it is. Here is another patient that when she was a newborn, she's a 13-year-old woman, when she was a newborn, she had a cardiac surgery for a correction of a Fallot disease. And afterwards, 10 years after, she started with plastic bronchitis. That is another complication that's common in chest and heart surgery. So we performed a CT lymphangiography, and we got to see what it looks like contrast around the bronchi. That might be the answer of what's happening with her. Another case of chylositis in our CT lymphangiography. Here at right, you can see the whole body and how the thoracic duct is all enhanced with the post-procedure. So what about our experience? What have we done? In just 1 year or a bit less, we've done 5 patients between 1 to 17 years. And there were 3 women and 2 men. In all of them, we had a successful intranodal injection of contrast. And in all of them, we got the central lymphatics to be opacified, and that's something really important. So what were our results? We had from 2 to 21 minutes after the 5-minute injection of contrast to see the whole thoracic duct enhanced. So after the 5-minute injection, we waited from 2 to 21 minutes to get the whole thoracic duct enhanced. Then this is a key point. We had only 31 to 64 minutes of anesthesia. And this is really important because against the MRI lymphangiography that lasts maybe the double of time. And the other key point that we were really aware was the radiation. The radiation was between 9 to 12 millisieverts. And we've been reading and we've seen that FDA says that an abdominal CT non-contrast has almost 9 millisieverts and a barium enema has almost 8.5. So the radiation was not as high as we thought at the beginning. So this is a really important thing to try the CT lymphangiography. What else? We also find that 3 patients, we only needed 1 scan to get the full thoracic duct enhanced. And in 2 patients, we needed 2. Then we had only 1 patient with chylositis that we did not find the leak exactly in the portion of the thoracic duct. And we didn't find any complications in our procedure. So here, what are our conclusions with all of this? We find that it's really effective in patients with lymphatic disorders to do the CT lymphangiography, and mainly it's an alternative to methods that may be more available and less time of anesthesia. And this is a key point of our investigation. Any questions? Thank you for your attention.
Congratulations, Federico, for your wonderful work with the beautiful images, and congratulations for your presentation. I have one question. Tell me how about the steps of this work. For example, do you have a special room for these children before the lymphangiography? How about this?
Yeah, it's a really interesting question. What we do is we take the patients into a pre-room before the CT scan.
Okay.
We talk to them, we explain the procedure, we explain what we're going to do, we do the consent, obviously, with their parents. And then when it's in the CT room, the patient is asleep, we take the ultrasound machine and we start with the steps, as I was saying, watching the ganglia and started with the puncture.
At this time, the patient was with sedation or not? When the sedation occurs?
The sedation starts just before. We do the ultrasound before the sedation to check how big the ganglia are, to find the ganglia that we are interested in puncture, that have a really good transitional zone, and then we start with the anesthesia just to be sure where we're going to do our work.
Perfect, very good work.